Hello everyone, this is Nursing 222, Medical Surgical or Nursing Care of the Adult 2. Today we are discussing Chapter 25, which is the sensory system, the eye and ear. First, we'll review the structure of the eye. This should be a review for you from anatomy and physiology. The eye is a spherical shaped organ. It is made up of several different parts. The first part that we'll discuss is the sclera. This is the opaque white part of the eye, the wall of the eyeball. The cornea is the transparent part of the wall of the eyeball. And then the middle layer consists of the choroid, the ciliary body, and the iris. The choroid is part of the middle layer. It is highly vascular. It contains brown pigment that's located between the sclera and the retina. The ciliary body is part of the middle layer of the eyeball as well. It contains finger-like ciliary processes that produce aqueous humor. The ciliary body helps change eye shape for near and far vision. The iris is the colored portion of the eye. It's donut-shaped and it has a diaphragm with the pupil as the central opening. The iris contains two groups of smooth muscles that constrict and dilate the pupil to regulate the entrance of light. The bioconvex transparent lens, suspensory ligaments, and ciliary body forms a partition that divides the inner eye into two chambers. The retina is the inner layer of tissue of the eyeball and is found in the posterior portion of the eye. The retina contains several layers. The layer with rods and cones act as the receptor for light images. The optic nerve carries messages from the nerve cells in the retina to the brain, and then the optic disc is formed by the axons of the ganglion cells of the retina. Next, we'll discuss the functions of the different structures of the eye. The bony orbit, it protects the eyeball itself. Eyelashes help trap foreign particles, keeping them from landing on the eyeball. The eyelids protect the eyes from foreign matter as well, and they help distribute moisture on the eye surface. The sebaceous glands secrete an oily fluid that lubricates the lids, and then the lacrimal glands produce tears. This is done by blinking several times a minute, up to from 6 to 30 times a minute, which helps to produce tears. The lacrimal gland, it secretes tears that moisten, lubricate, and cleanse the surface of the eye. Tears contain an enzyme that helps destroy bacteria and prevent infections. The transparent cornea allows light to hit the lens. It assists with the bending of light rays so that the rays will hit the retina in the right location for images to be transmitted to the brain. The choroid's brown pigment absorbs excess light rays that could interfere with vision. And then the ciliary processes secrete aqueous humor that helps maintain the shape of the anterior chamber of the eye. It also nourishes the structures in this part of the eye. The aqueous humor assists with refraction of light onto the retina, and the amount of aqueous humor present determines the internal pressure of the eye. Muscles in the iris control dilation and constriction of the pupils. The suspensory ligaments connected to the ciliary body and lens allow light to focus on the lens and the retina, which is necessary for close vision. The retina's rods and cones are photoreceptors for light and color. The nerves of the retina transmit the images perceived to the brain. The optic nerve, it allows visual impulses to travel along the optic chiasma just anterior of the pituitary gland, and these travel to the brain where the images are processed. The optic discs in your eye They help to regulate pressure within the eyeball and within the skull. When intracranial pressure gets higher, the optic disc appears swollen or kind of a choked appearance. There are 6 intrinsic muscles of the eye. The superior rectus is controlled by the oculomotor nerve. This elevates eye or rolls it superiorly and toward the midline. The inferior rectus is also controlled by the oculomotor nerve. This depresses eyes or rolls it inferiorly or toward the midline. The medial rectus is also controlled by the oculomotor nerve. This muscle moves the eye medially toward the midline. The lateral rectus is controlled by the abducens nerve. This muscle moves the eye laterally away from the midline. The superior oblique is controlled by the trochlear nerve. This muscle depresses the eye and turns it laterally away from the midline. And then we have the inferior oblique muscle. It is also controlled by the oculomotor nerve. This muscle elevates the eye and it turns it laterally away from the midline as well. Then we have the intrinsic muscles of the eye. The ciliary muscle is controlled by the oculomotor nerve. It is made up of parasympathetic fibers. This muscle causes suspensory ligaments to relax, so the lens becomes more convex for close vision. The circular muscles are within the iris. This is also controlled by the oculomotor nerve. They are also made up of parasympathetic fibers. This muscle decreases the size of the pupil to allow less light to enter the eye. And then we have the radial muscles. These are also contained within the iris of the eye. They are controlled by sympathetic fibers from spinal nerves. This muscle increases the size of the pupil to allow more light to enter the eye. Next, let's discuss some age-related changes of the eye. First off, subcutaneous fat and tissue elasticity decrease with age. This gives the eyes a sunken appearance. Arcus senilis is something that you may see within the elderly adult. This is an opaque ring outlining the cornea. It's a result of fatty globule deposits within the eye. A lot of times this will also appear like a blue ring around the cornea. The cornea itself flattens and it develops an irregular curvature after the age of 65. This can cause astigmatism or it can make an existing astigmatism worse, which will cause the vision to become blurry, and then cornea transparency also decreases with age. The sclera develops a yellowish tinge from fatty deposits, and then thinning of the sclera may cause a bluish tinge. The ability of the iris to dilate, it decreases with age. This causes difficulty for the older person to go from very bright light into a darkened area. The lens of the eye changes after the age of 40, and it gradually loses water and it becomes harder, and cataracts may form as a result of this. The ciliary muscle has less ability to allow the eye to accommodate and process responsible for the gradual extension of distance from the eyes at which an item to be read is held. This is known as presbyopia. This change usually begins around age 40 years. The farthest point at which an object can be identified, it decreases with age. This is known as nearsightedness or myopia. And then also the visual field narrows as well. And pupil size becomes smaller, reducing the ability to see in dim light. Other age-related changes that can occur um, are where moisture secretion, it decreases with age. This places the eyes at greater risk for irritation and infection. This is especially common after 70 years of age. Repeated episodes of keratitis, which is inflammation of the cornea, may compromise vision and can lead to loss of independence for these individuals. Eversion of the lower eyelid is known as ectropion. This occurs because the loss of muscle tone and elasticity with age occurs. And then there is decreased muscle tone and decreased elasticity that might cause drooping of the upper eyelid to a point where it interferes with vision. This is known as ptosis. Okay, let's discuss some eye disorders. There are approximately 21 million visually impaired individuals in the U.S. 5.4 of these individuals, or 5.4 million of these individuals, are greater than 65 years of age. There are two kinds of vision impairments. The first is a genetic component, or one which the individual is born with. And then the second type is the development of an impairment as an individual ages. Causes can be from injury or disease, or disorders, again, where there's a genetic predisposition. Different diseases like diabetes, mellitus, hypertension, they can cause disorders of the eyes. Macular degeneration is another major vision impairment that occurs with aging. This causes loss in the center of the field of vision. There's a couple different types, but mainly it's good to know that there can be fatty deposits that develop under the retina, or there can be leaky blood vessels that grow under the retina that will then decrease the center of field of vision, and that's known as macular degeneration. Also, AIDS can cause blindness as well. So someone that is advanced in the disease of AIDS may also suffer from blindness as that disease progresses. So as the nurse, it is our responsibility to help educate patients on how to prevent visual disorders. So some of that education includes resting the eyes periodically to prevent strain. So if individuals work at a computer for long hours, they watch television, they might do cross-stitching or sewing or quilting, and then any other activities that would require intense visual effort. These individuals need to be encouraged to rest their eyes periodically to prevent strain. And then some signs and symptoms that an eye exam is needed would include purulent drainage or excessive tearing. This usually requires an eye exam. If the eyes tire easily, the patient experiences frequent headaches, burning, itching, or redness of the eyes, they also need to be examined. And then it's important to educate our patients over the outline for a basic eye exam. So adults with no other risk factors should begin baseline eye exams at the age of 40, and then every 2 to 4 years after that, it needs to be repeated, and every 1 to 3 years from ages 55 to 64. After the age of 65, the eye should be examined by an eye specialist every 1 to 2 years. So preventing eye injury includes educating patients over the correct use of protective eyewear. Individuals need to be educated over the life of makeup. So eye cosmetics need to be discarded every 6 months, as well as brushes, unless you are able to clean those brushes thoroughly and disinfect them. You should not use saliva to moisten your eye makeup. Some individuals will use it to moisten eyeliner and other things that they may apply for cosmetic purposes. This needs to be discouraged. And then individuals also need to be educated on not sharing eye makeup amongst one another. That is also a vector for infection. So preventing vision loss. This includes, as the nurse, we need to educate our patients over the different diseases that can contribute to vision loss. These diseases include diabetes and hypertension. When these diseases are uncontrolled, they can cause vision loss. Patients with these disorders are more susceptible to retinopathy, and we as nurses need to encourage good control over these diseases. So that would include diet, exercise, taking the medications as prescribed, and not discontinuing medications without first talking to their primary healthcare provider. An individual needs to seek medical attention immediately if they believe their cornea has been scratched or abrased. So if they're out hiking and a branch hits their eyeball and they have a watery eye with blurry vision and lots of pain, this individual needs to go to the ER immediately. We can also assess elderly for cataracts. They would do this by you would recommend periodic eye examinations with an ophthalmologist where they would assess for cataract development. And then it's also important to note that Latinos are found to have high rates of diabetic retinopathy and open angle glaucoma. So what this means is this is probably a demographic of patients who may not be seeking frequent medical care or doing their yearly physicals. So individuals need to be encouraged to see their provider at least annually so they can have a full physical workup done, lab work ran. Any diseases such as diabetes and hypertension should then be detected, and we can start these patients on therapy or treatment to help control these diseases so that hopefully we can prevent vision loss for these individuals. Okay, there are several different diagnostic tests that we can do for different disorders of the eye. There is a table on page 576. It's table 25-2. And this table continues on to page 578 that I would like for you to review and study. And then also, with your beginning of class activity, you were given a diagnostic test. You were asked to label the purpose, the description, and the nursing implications for that test. And it is listed on the glossary for your beginning of class activity on Moodle. So please also review that glossary that you and your peers developed. So nursing management of eye problems. First, we need to collect data or to perform a thorough assessment. Any nurse is capable of doing a basic eye exam. You would observe the eye for movement. You would observe the color of the eye, observe for any abnormal secretions, and then observe pupillary response to light. It's also important to perform a thorough patient history. We need to ask these individuals if they've had prior trauma that has occurred to any of the eyes, if they have familial history of any disorders of the eyes. It is very important to ask patients about this history. For instance, I had a patient one time when I was working in surgery who I received from the recovery unit. So I was in the step down unit or step down 2 unit and taking care of this patient. As he's awakening, I noticed that one of his pupils it's fixed. It would not dilate. And so immediately I became a little worried because there are several different causes of pupil fixation. A lot of those include central nervous system involvement, so strokes can cause that, encephalitis, different issues that may occur during surgery, um, or just injury to the eye itself during surgery can occur because these patients are given a medication that makes them immobile. It actually causes them from moving at all, and so the nurse anesthetist is often in charge of protecting that patient's airway along with anything above the shoulder, so that includes their eyes. And so they could have withgone or undergone a trauma during surgery to their eye that no one was aware of. However, upon talking to the patient and the patient's wife, I found out that the patient had had a previous injury to his cornea earlier in life, and his pupil is always fixed. So I did not have that information available to me in this patient's history and physical that was obtained before surgery. Had I had that information, I would have been a lot less alarmed. I would have known to expect this change in my patient, and I probably wouldn't have gotten initially so worked up. However, I just asked the patient and the patient's significant other if this in fact was normal before I jumped to any conclusions and went off and called the physician about it. But it is important to know those types of things, or else you may find yourself questioning whether something very serious has just occurred, and should you then call rapid response or code, how do you need to treat this patient going forward? So that's important information to have. So with that being said, data collection for eye disorders is very important. Any recent visual changes that the individual may be experiencing, whether it be seeing spots, having visual field changes, whether they see halos around different objects, we need to assess for any visual changes. Are these individuals experiencing any eye pain or discomfort? Do they have trouble seeing at night? Do they have trouble seeing in bright lights? Do they have previous eye injuries that may affect an assessment? Are they experiencing excessive discharge or buildup of discharge in the mornings upon awakening? Do these individuals wear glasses or contacts? What medications do they take? Different medications can affect eye health. Is there any familial history of eye disorders? And then when was their last eye exam? And then also a physical examination may be necessary as well. We're going to observe these patients for redness, conjunctivitis, swelling of the periorbital space or their eyelids, any excessive tearing, visual changes, visual acuity changes, secretions, incrustations, and abnormal position of the eyeball itself, known as ophthalmosis, which is protrusion of the eyeball, and then xanthelasma, or the soft raised yellowish areas around the eyes. These appear on the eyelids after the age of 50 years of age. They're often kind of like calcium buildup or deposits around the eyelids. Okay, so we'll discuss a couple of different eye diseases. The first one we're going to talk about is blepharitis. This is an infection of the glands and lash follicles along the lid margin. Signs and symptoms include itching, burning, sensitivity to light, mucus discharge and scaling, crusted eyelids. The eyelids may be glued shut, especially upon awakening in the morning, and there may be loss of eyelashes as well. Medical treatment and nursing interventions include warm, moist compresses to soften the secretions around the eyelid. The eyelid may be scrubbed gently with Q-tip and the use of baby shampoo, and then stroking sideways to remove the exudate and scales from the eyelid itself. They may also require antibiotic eye drops or systemic and topical antibiotics if the skin around the eye is infected. The next disease is chalazion. This is an internal stye. This may cause astigmatism or distorted vision. And depending on the size and location of the chalazion, there may be small and hard tumors on the eyelid itself. This is treated by surgical excision and possibly antibiotics to prevent a chronic state of this disease, and then to prevent cyst formation. Hordeolum is an external stye. This is an infected swelling near the lid margin on the inside of the eye. Signs and symptoms include sharp pain that becomes dull and throbbing. There may be a rupture and drainage of pus along the lid line. The medical treatment and nursing interventions include warm, moist compresses 4 times a day for 10 to 15 minutes to bring the stye to a head and hasten a rupture. Hordeolums usually resolve spontaneously on their own. Caution does need to be given to the patient to never squeeze the area because this could spread infection. And then poor health status can predispose a person to recurrence of styes. The next disease we'll discuss is conjunctivitis. This is inflammation of the conjunctiva, or the pink eye is what it's usually called. It's caused by chemical irritants, bacteria, and viruses. Signs and symptoms include varying degrees of pain and discomfort, increased tearing and mucus production, itching, sensation of a foreign body in the eye. Medical treatment and nursing interventions include antibiotic eye drops and ointments, special care when handling infected material, and then it just depends on the type of infecting organism, what medication these individuals will be prescribed to treat the conjunctivitis. Keratitis is inflammation of the cornea. This may present with varying degrees of pain and discomfort. Usually it's accompanied by photophobia or blurred vision if the center of the cornea is infected. Medical treatment and nursing intervention depends on the specific cause. It could be caused by an allergy, microbes, ischemia, or decreased lacrimation. Most superficial lesions are self-healing. Antibiotic eye drops or ointment may be used for bacterial infections. Steroids can reduce inflammation and discomfort. And then a herpes infection can rapidly worsen keratitis unless an antiviral agent is given simultaneously. The patient is encouraged to use good personal hygiene and frequent hand hygiene. And then the last disorder we will talk about is a corneal abrasion. Signs and symptoms include moderate to severe pain and discomfort aggravated by blinking. This is often a cause or a result of trauma to the eye, and sometimes individuals that wear contact lenses can also suffer from a corneal abrasion. Medical treatment and nursing interventions include changing or discontinuation of contact lenses if this occurs. We will teach the patient proper ways to insert, remove, and care for contact lenses, and then we need to caution the patient not to moisten the lens with saliva. So now we're going to discuss proper installation of eye drops and eye ointment. For eye drops, first you're going to remove the cap on the drop bottle and place it on its side or upside down on the table. Then you will ask your patient to sit in a reclining position and ask them to look up at the ceiling, tilt their head slightly toward the eye that's receiving the drop. You'll place a tissue beneath their eye with your fingers, and then retract the lower lid downward, exposing the conjunctival sac. You'll want to stabilize the eye drop container above the eye and drop the designated number of drops directly into the conjunctival sac. And do not replace the drops on the cornea. Block the entrance to the lacrimal gland by placing a finger over it. and then carefully replace the cap on the container without contaminating the dropper lid. For eye ointment, you will remove the cap from the tube and set it down on the table on its side. You will need to expose the conjunctival sac, apply a thin, long ribbon of ointment along the entire length of the conjunctival sac, and then to end the ribbon, you will need to twist the tube with a lateral movement of the wrist without touching the eye. Recap the tube and ask the patient to gently close the eyelids and roll the eyes around under the lids to distribute the medication. A lot of times people that suffer from vision loss will suffer from depression and anxiety as well, so we need to provide them with the appropriate emotional support for them as well as their family members. You need to communicate properly with your patient. Please remember that they are visually impaired, not hearing impaired, so please speak to them in a normal tone and volume. You do need to identify yourself when you enter the patient's room. Please do not touch your patient until you have announced your presence to avoid startling your patient. And then you do need to orient your patient to their surroundings. Prevention of injury is also a priority for these patients. So again, orient your patient to their surroundings, make sure they know the location of their call light. If it is mealtime, you will need to familiarize your patient with their meal tray. You can use the clock approach, or I like to guide the patient's hand to different areas on their tray and tell them what the different areas contain. For instance, their meat might be right in front of them. You guide their right hand up to the right corner of their tray. That might be their salad. You need to tell them where to locate their utensils and their drinks as well. And then if these individuals are using a guide dog, please know that they are specially trained, and you need to avoid interfering with the dog at all costs. That means no petting the dog, no feeding them treats, or otherwise interacting with the dog. They are working. They are trying to fulfill their responsibilities, so please do not disrupt the dog. We will very briefly discuss the structures of the ear. The external ear consists of the pinna. This is the fleshy part of your ear that's visualized on the side of your head. The auditory meatus is a tube that is approximately 2.5 centimeters in length and extends from the pinna to the tympanic membrane. Then you have the meatus. That is where your cerumen is produced, or earwax. And then you have your middle ear that contains the auditory bones. The auditory ossicles are three small bones, the malleus, the incus, and the stapes. The malleus attaches to the tympanic membrane, and the stapes attaches to the oval window. The tympanic membrane separates the middle ear from the external ear, and then the eustachian tube connects the middle ear with the throat. The oval window and the round window connect the middle ear to the inner ear. And then you have the inner ear, which is divided into the vestibule, the semicircular canals, and the cochlea. The inner ear contains a bony labyrinth with a membranous labyrinth lining. The inner ear is located in the temporal bone of the skull. A clear fluid, endolymph, fills the membranous labyrinth. And then the cochlea contains the organ of Corti, which is composed of sound receptors. Functions of the ear. The pinna, or the outer portion of your ear, it collects sound waves. And then hairs and cerumen within the meatus help prevent foreign objects from reaching the tympanic membrane so that a patient or individuals do not suffer from any injury to their eardrum. The tympanic membrane vibrates and conducts vibrations to the malleus. The middle ear bones transmit the sound vibrations to the inner ear. Fluid motion in the inner ear stimulates sound receptors in the cochlea and the organ of Corti. And then the organ of Corti transmits sound impulses to the 8th cranial nerve, and then onto the medulla oblongata, the thalamus, and then to the temporal lobe of the brain, where these sound waves are processed to information. And then the inner ear is responsible for equilibrium. This is achieved with The bony vestibule at the base of the semicircular canals. Impulses from equilibrium receptors are transmitted to the brain via the vestibular branch of the vestibular-cochlear nerve, which is another eighth cranial nerve. And then the cerebellum is the important part of the brain that mediates the sense of equilibrium and balance within the body. So some common age-related changes that occur within the ear as we age are the cerumen or the earwax may become harder, containing less moisture, and builds up within the ear to contribute to hearing loss in low frequency ranges. The tympanic membrane also loses elasticity, which may contribute to hearing loss as well. Joints between the auditory bones become stiffer, and the stiffness interferes with the transmission of sound waves, but it is not clinically significant by itself. There is also a gradual loss of receptor cells in the organ of Corti after the age of 40, and then a number of nerve fibers in the vestibulocochlear nerve decrease, contributing to hearing loss and sometimes affecting balance and equilibrium as well.